Our first speaker is Dr. Annaliese Cothron. Dr. Cothron is the co-founder and executive director of the American Institute of Dental Public. She received her Bachelor of Science and Master of Science degrees from Mississippi State University, specializing in experimental psychology with a theme in applied statistics. She received her Doctor of Health Sciences from A.T. Still University and has a certification in nonprofit management and fundraising from Our Lady of the Lake University. After moving to San Antonio, she worked at UT Health San Antonio School of Dentistry for 8 years as the evaluation coordinator for 2 school-based sealant programs, teaching as a core instructor in the dental public residence and serving as executive director of the Texas Repository of Oral Health Data for Evaluation and Outcomes. She serves as a board member for several organizations, including the Texas Impact and Texas Oral Health Coalition. Welcome, Dr. Cothron.
Hi, everyone. I'm so excited to be here today. Thank you so much for having me. I just want to acknowledge, I feel like in this virtual environment that we are all needing to give each other a little bit of grace, right? So if I have technical difficulties or if you hear background noise, I hope you'll just bear with me as we all work through having life in the midst of this pandemic. And if we were here in person, I would probably be having everybody stand up and do some stretches and having a lot of interaction in an in-person presentation that is not necessarily compatible with a virtual presentation. So I'm trying really hard to create a space where we have interaction and that we're able to really get some conversation going. So today I'm going to be presenting Are We Unified and Approaching Oral Health Equity, a National Perspective from AIDPH. And so I hope that everybody has your chat ready because I'd like to kind of go through and build in as much conversation among us as we can today. So I thought it might be a good idea first, however, to start with the history of AIDPH really briefly. We are a newer national organization. We were founded in 2015 by myself and Dr. David Capelli, the chair of our board. And really that was catalyzed through funding from the Health Resources and Services Administration through a postdoctoral training grant. And so initially we focused on creating programming and educational experiences for dental public health specialists, for future specialists, and really focusing on preparing them for an equitable environment as they matriculate into the oral health workforce, while also supporting creative programming for current oral health professionals. And as we sort of went through this process of building AIDPH, the past year and a half, we've focused on almost essentially a gap analysis of the oral health community and looking at where opportunities lie for AIDPH to be amplifiers and supporters of the oral health work across the country, like this opportunity right here to amplify the work of the Louisiana Oral Health Coalition. So I'm really excited to be here and talk about some of the work nationally that's being done around health equity. Again, really amplifying the current data, the current landscape, and how we can kind of bring some successes and solutions into oral health equity. But before we get into that, I thought I would go through just a touch of housekeeping. And so number one, like I've already mentioned, I'm trying really hard to create conversation here around oral health equity, and all of your voices are actually really critically important to that. And so there'll be times that I'm not going to ask you guys to chat in some thoughts. I would love to respond to you. So totally fine to talk to each other during the presentation. That does not offend me for you guys to create conversation on the side here. And I just ask that whenever we chat in that you hit panelists and attendees so that everybody can see your comments. And we'll hold general questions till the end because we've built in a lot of interaction. So I hope that that'll be okay just to hold questions. If you do want to ask me a question directly, you can use the Q&A function in Zoom to do that. And I'll make sure to wrap up at the end and answer those questions. And then lastly, if you are willing and able, if you can add your personal pronouns to your Zoom chat name. So this is, again, one of those equitable practices that I have found to be really helpful and inclusive. And as you can see on my name, I am Annalise and I use she, her pronouns. And so if you're able to do that, to rename yourself on Zoom, it's really easy to do if you click the box by your name in the chat on the person side, on the attendee side, there we go. And just rename yourself with your pronouns. And I found, again, that's an equitable and inclusive practice that we can facilitate as oral health equity champions. And another equitable practice, in case you haven't seen it before, is a land acknowledgement. So I'm coming to you here from San Antonio, Texas. We're national in scope at AIDPH is founded and incorporated in Texas. And so it's really important for us to acknowledge who has been here before us and the enduring relationship that exists between Indigenous peoples and their traditional territories. And the goals for this session today, for the next about 45 minutes, are to identify the facilitators and barriers to oral health equity. What are some of the upstream and downstream influencers of oral health equity and associated outcomes? Hopefully, we can evaluate the current capacity of the oral health workforce to promote oral health equity. And lastly, we're going to apply some systems change thinking, although that is always really difficult because it's so complicated and complex. But hopefully we can think about ways that we can change systems to advance equity in oral health. And then lastly, I borrowed this phrase from my colleague, Dr. Sean Boynes at the DentaQuest Partnership, but I'm really not here to provide solutions or to present solutions. Hopefully, the overarching goal of our time here today is for me to provide some national context around oral health equity, but really to start conversation and perhaps provide some frameworks for you all to find the solutions for your community. So I am not, here to provide solutions, but hopefully I can provide a space to think critically about solutions in oral health equity moving forward. Okay. So it's always helpful whenever we're talking about any topic to think about how we define it, how we measure it, what is health equity, how are we understanding it? And I think this is the good time to actually ask all of you, what does health equity mean to you? So if you can move over to the chat and think about in 3 words or 1 word or whatever keywords that you think of, what does health equity include? What does that mean to you whenever you think about it? Ooh, justice. Whoa, starting out strong. I love that, Madeline. That's great. Everyone has an equitable chance to thrive. I actually like that emphasis on thriving. It's not just about being able to access, it's about thriving in your community. Quality, having it be for everyone. Health services availability. What else? Universal access to healthcare, total inclusion, no payment barriers. I think these are all really important. Any last minute additions to the question? Regardless of your background, attaining access to healthcare. So the reason why I asked this question, and you guys can keep chatting them in for sure, and feel free to respond to each other in the chat. Oh, I like that, fairness, not equality, right? Because that's really what equity is about. It's about what's fair and just. And why I asked this question is because this was part of a research study that I conducted recently. And the study itself had to do with health equity and anti-racism and racial equity. And this question always provides really interesting responses. And here's a word cloud of almost 300 people, dental public health professionals, oral health professionals, who were asked, what does health equity mean to you? What is that definition? And I thought, again, just like here, the definitions and what people found to resonate with them was really interesting. And so, aside from those big words in the middle, like health and healthcare, which we would expect to see and how people define health equity, the big pieces, it really is resonating with exactly what I see in the chat here, that it's about equal access. It's about individualized ability and opportunity to get what you need. It is inclusive of everybody. And it's really about accessing the right resources at the right time um, to get the best outcomes related to health, right? And so I think this is interesting and important to talk about in relationship to health equity, because there is not really a clear and very standardized way of defining and measuring health equity, particularly oral health equity. In fact, there's not really a definition of oral health equity, but rather we consider oral health within the broader context of health equity. So I have a few definitions here. The Robert Wood Johnson Foundation is typically my favorite definition to use, because I think it has a lot of meaning hidden in this definition, including powerlessness and the lack of joy and hope. And it's all about really everyone having a fair and just opportunity, which I think is really critical to think about with oral health equity. But the World Health Organization has a streamlined definition as, the absence of unfair or avoidable differences. The CDC says that health equity is achieved when every person has the opportunity to attain their full health potential. And then HRSA is another example, very similar to sort of the World Health Organization. It's the absence of disparities or avoidable differences. And I just pulled 4 here, but really I could go on and on and on, because there are a lot of both global and national and even state and local definitions of what health equity actually means. And some of these commonalities, though, is that they all across the board involve social and physical and structural facilitators. So there are influences that are both on the individual and social and structural level. And those all influence differences in health outcomes. So when we're talking about health equity, this is probably my favorite visualization of health equity, although it is complex. Health equity in and of itself is really complex. And so I've pulled this from the Bay Area Regional Health Inequities Initiative, or BARI. And I like this framework because I could probably spend an entire presentation just right here on this framework, piecing it out and sort of deconstructing it. But what I'd like you to sort of recognize here is that health equity has so many different facilitators, barriers, influences, and risk factors that are all built in to the definition of it. There are upstream solutions. So those are those big structural changes, like policy. So the ACA, that's a big, huge upstream solution, a huge shift in policy that allow for more equitable access to care. And then there are more downstream solutions, which are really working on the repercussions of health inequities. So treating disease and injury instead of preventing them, which is more of an upstream solution. It's treating or identifying those risk behaviors on an individual level and really managing people on an individual level. And here in the very center, we talk about living conditions and the environment that we are all in that impacts whether we have facilitators or barriers to health equity. And what I like here at the very bottom that I haven't seen in any other visualizations around health equity is that there are current public health practices and then there are emerging public health practices. And all of you have the opportunity to incorporate yourselves into each piece of this puzzle. So many of you, I'm sure all of us here on this call, are looking at current public health practices. We're all incorporating best practices, considering where we are right now, how we can respond with what we have. And then thinking ahead, those emerging public health practices are really critical to be thinking of those upstream solutions and moving them into more equitable access to care, right? So that's how I'm defining health equity, and that's sort of setting the context for what we're thinking about today in terms of health equity. But on top of that, I also think it's important that we consider the current landscape of health equity. And I'm looking in the chat, rural access, institutional politics. I think those are all really good additions and are folding into that huge visualization of how we're influencing health equity. So thank you for adding that. That's a great bonus. So where are we currently at with oral health equity? How are we doing currently in that current public health practice piece of that visualization? Where are we at right now? So just looking at the facts and the data, oral disease on a global level affects nearly 3.5 billion people a year. And so oral disease is pretty consistently listed by the World Health Organization as one of the top diseases, if not the top. There have been some years that it's been listed the top disease in the world. So oral health is not just a United States issue. It's not just a Louisiana issue. There's a huge burden globally related to oral disease. So looking specifically at the US, more than a quarter of adults have current untreated decay, and more than half of them have gum disease. So the burden of disease is not just high globally, but specifically here in the US, it's incredibly high. And it's resulting in these really painful processes that are, again, going untreated. Each year, and this data was from 2013 and 2016, over 15% of the US adults needed dental care, but couldn't get it. So globally, there's a huge burden. Here in the US, more than a quarter of people have current disease, and 15% of them need to treat it and can't get it. So there are barriers to receiving and treating oral health care. And because there is such a huge burden, and because people are struggling with being able to access care and meet their needs, we're spending almost $3 billion annually in hospital emergency departments to treat dental conditions. So, where is this always located, right? It's disproportionately affecting people who are in low wealth areas because those people cannot visit a general dentist. We know that here in the US, a systemic problem is that your health care generally, and even more so for oral health care, is connected to your employment. It's connected to your ability to have an employee that pays for you to have access, or an employer that pays for you to access oral health care. We know this is not equitable. We know this is not just. And we also know that this oral systemic connection is very clear. That oral health is not just about whether or not I have a smile, or on the very basic level, whether I'm pain-free. But in what was presented in the video this morning by Lisa and Marcia Beatty, who talked about this is actually such a huge economic connection too. When I do not feel confident and healthy smiling at a job interview, I am not going to get that job. When I'm not seen as personable because I have a problem with my teeth, maybe they're discolored, or I'm experiencing pain, that affects my productivity. And it affects our productivity to the tune of $153 billion in lost productivity every year. So not only does oral health equity and the burden of oral disease, not only is that influenced by, our lack of access to care, and not only is it decreasing our quality of life here in the US, but it's also really challenging our economy and our opportunity to be financially viable. And you're talking about in a country that has the third highest GDP and has some of the worst, as it relates to healthcare, and has some of the worst health outcomes. So this is not a difficult connection to make, that we are spending our healthcare dollars inappropriately on trying to mitigate the effects of oral disease rather than prevent it. And is that how we should be experiencing health equity? I'm sure everybody here would say no to that. And it's critically important for us to always remember that every single negative health outcome in oral health as well are always going to be more severe for BIPOC communities. And by BIPOC, I mean Black, Indigenous, and people of color. So communities of color are always going to experience these outcomes more severely, and that is a direct result of racism. So we talked about this globally. We talked about this here in the US nationally. So what are states doing to facilitate oral health equity? So we've already talked about, and Michonne did a wonderful presentation. I know I learned so much about what does the state of the state, what does the state of Louisiana look like? And that's not uncommon. This is what coalitions do across the nation, right? We talk about state oral health plans. I'm on the board of the Texas Oral Health Coalition. We talk about state oral health plans. We talk about our report cards. This is a really common way of understanding the needs of your community and how you can develop strategies to improve oral health on a state level, right? And then lastly, state oral health plans typically include some sort of mechanism of measuring how you're making progress and ways to continue to evaluate that progress. So as Michonne already talked about, the ASTDD, the Association for State and Territorial Dental Directors, puts together a sort of compendium of all of the state oral health plans, and talks about whether or not a state has an oral health plan, and then you can access all of the state oral health plans too. So everybody get ready, because we're going to do a little bit of chatting and interaction here. But I was actually interested in looking at equity in terms of state oral health plans. So I've got all of this data from the ASTDD website. And question number one, of the 50 states, how many states do you think, and you guys better not cheat, do not go to the ASTDD website. Scouts Honor, I can't see anybody. But of the 50 states, how many states do you think have a state oral health plan? If you had to guess. Okay, Celeste is saying 35. Anthony says 0. Seeing 40. 37, 25, 10. Of the 50 states, how many do you think have a state oral health plan? 5, 15, 30. So we have anywhere right now from 0 to 40. So we have a pretty wide range here in the chat. Anybody else want to get in their guess under the wire before we reveal? 25, 15. 2 more seconds to throw in your guess. 46. Kind of feel like Price is Right, like, oh gosh, don't go over. Okay, so of the 50 states, 30 have a state oral health plan listed on the ASTDD website. So Andretta, you get a prize. Who else? It looks like Andretta was the only one who got it. So prize to Andretta. It'll have to just be my thanks, because I don't have prizes for anybody, but you get a gold star for this session. Okay, so then thinking about, of the 50 states, and 30 of them have a plan listed on the ASTDD website. Of those 30, how many have a plan that was actually developed in the last 5 years? And again, Michonne gave us an overview that typically these plans are updated about every 5 years. And I was generous and gave everybody a year since we're still early in 2021. So has a plan between 2014 and 2020 that's considered current. Of the 30. Okay, I'm seeing a 15. 12, 27, 20. Got a couple votes for 10. Any last minute guesses? 25, 15. Okay, 17. Very close, Kimberly. 18 states have a current plan. So did anybody get it right on the nose? No, but you know what? Kimberly got very close. So gold star to Kimberly. 18 states have a current plan. Now, how many states have equity in their state oral health plan? That does not have to be a current plan. It does not have to be, you know, of all of the 50 states, how many do you think have equity in their plan? 3. See, I guess for 3. 25, 8, 5. 22, 7, 10. Any other votes? I'm giving out gold stars over here. 0, 17. Okay, so of the 50 states, 7 states just mention the word equity, and 7 states actually have a goal associated with equity. So when we're thinking about equity and how we are measuring oral health, and how we are surveilling oral health, how we are doing needs assessments related to oral health, I think there's a case to be made that we could probably be doing a lot better, right? So your homework, although I'm sure most of you are from Louisiana, if you're joining us from another state, your homework is to actually go to the ASTDD website, and you can do this by Googling. You can just Google ASTDD and then state oral health plans. That's exactly what I did. And find out if your state has a current oral health plan, so developed within the last 5 years, and does your state include equity and a goal associated with equity? Does it use that word, and are you creating plans that promote oral health equity? And then lastly, I think it's just really critically important to talk about racial equity and what this means in the context of oral health. So this is not surprising that 2020 brought about social consciousness that was really a reckoning around racial equity that we haven't seen before, really since the civil rights movement. And throughout healthcare and throughout many health sectors, lots of leaders, of thought leaders, talked about and created calls to action as it related to racial equity and health. So there were publications from nursing, public health education, emergency medicine, medical student, pediatrics, all saying we have to do better as practitioners to advance racial equity. And unfortunately, it's been crickets in oral health. We have not developed clear research-based calls to action to advance anti-racism in oral health as practitioners and as a community. So I know there are a lot of organizations working on this in oral health, AIDPH and Open being some of them. You know, we just recently collaborated to create a call for racial equity and National Day of Racial Healing in January. But nobody has developed a clear praxis for understanding what anti-racism looks like in oral health equity. So there's a clear opportunity for us to be sort of supporting this racial equity landscape that we're seeing as it relates to oral health. So in that vein, I want to ask, what are our best opportunities for success? How can we really be successful in advancing oral health equity? So I'd like to present a framework here that we actually did. If you joined us last year when we were able to meet in person in January last year, we did this exercise at our AIDPH annual colloquium, which when we were meeting in person, it's in January every year in San Antonio. And last year we focused on oral health equity and policy. And so this exercise was actually completed with participants. And this was developed by the Reyes Partners, and this was funded by Robert Wood Johnson Foundation. And essentially what this group of people did is they analyzed and interviewed what health equity meant with a whole bunch of diverse key stakeholders, and developed this framework about thinking about health equity differently. So what I like about this is that there are a lot of things in this health equity framework that I haven't seen other places, and I thought I would just share it here today with all of you. So in terms of embracing health equity, there are sort of 4 key areas that they identified, and one of them is adopting a systemic view to reveal hidden opportunities, which I think is really critical, hidden opportunities. Leveraging equity-based approaches to remove those entrenched barriers. And here's really a key phrase: balancing out power. Changing our narratives. And again, I haven't seen this before, but changing and transforming how we talk about health equity to create imagination and spur creativity. We know those solutions around oral health equity, those strong opportunities, have to be creative to uncover those hidden opportunities and spur creative solutions, right? And lastly, convening stakeholders, which is what we're doing here today. This is a practice and an opportunity within oral health equity. We have to nurture those relationships with each other and build that collective impact. And so these were the factors that they identified that actually impacts health equity. And if we were meeting here in person, I would love to have done this exercise with you like we did with attendees last year. But what we actually had the attendees do is break out into small groups, and attendees chose sort of 3 key factors that they thought were really important of these 8, and then talked about how those key factors interacted with each other to either facilitate or provide a barrier to oral health equity. And, I would love to hear all of your responses. Feel free to chat them in if you have thoughts about it. But again, what I really like about these factors that I don't see anywhere else, and I think is really critically important for us to consider, is power. I don't see enough talking about the imbalances of power, and that can be power with leadership, power with funding, power with all of those privileges that we hold: racial privilege, LGBTQIA privilege, and how all of those things interact with each other to create hope, right? I never see the discussion about how critical it is for us to create hope in our communities and in ourselves in order to change for a more equitable environment. So I am wondering, of these sort of 8 areas, where is the position? Where's your position in this process? And how do you think you can advance health equity in these 8 areas? Where do you feel like you have the most opportunities for success personally in these sort of 8 areas to advance health equity? So Anthony's talking about connecting with others, connecting with self and others. Ooh, this is really interesting. So there's been a lot of responses here: connecting with others. That's where we feel like our strength is. Anyone else? Again, where is your position in the process, and how do you think you have the opportunity to advance health equity in here? Not surprising, a lot of people are feeling like connecting with self and others. This is great. So hold on to that, because I think these are really important for us to consider moving into the breakout sessions that we'll be looking at later today. Think about your role in advancing health equity. Think about the power that you have, what you're bringing to the table, how you're connecting with yourself and with others, and how, as Michael put it in, how you're leading by example, or how you're taking a step back from leadership and allowing other voices to lead. I think I'm going to skip through this slide because I do want to get to questions and discussion here today. So, how do we know we are succeeding? We've talked about what health equity is, where we currently are, and some of the gaps that we see here. And some opportunities, right? Some factors, some influencers, and where we see ourselves in that opportunity. So, how do we know that we are succeeding in health equity? How do we know that we are advancing health equity? And I thought I would share a really great tool that I picked out from the Annie E. Casey Foundation, because I do feel really strongly that we have to be able to understand the impact that we're making. And sometimes I think equity can be thrown around as a buzzword, and we forget that we actually have to make measurable progress here. And what I like about the Annie E. Casey Foundation's equity impact analysis is that this is a really wonderful framework that you can take back and use in your organization, you can use personally. And this isn't prescriptive. These are actually a series of questions that allows you as an individual to assess the equity and the impact that you may be having on health equity. So question number 1, are all disparate groups who are affected by the effort participating in the process? So if I am designing a program to advance oral health equity or to get access to marginalized populations, are those people who are affected by that effort, are they participating in the process? Are they informing the work? How will this work actually affect each group of people? Are there unintended consequences that we could think critically about before even implementing anything that could negatively affect other groups of people? How will the proposed effort be perceived by each group? And I think this is really important. I know that when I was working in Miles of Smiles Laredo, we worked at a dental sealant program on the Texas-Mexico border, and it was really important that we develop trust and rapport, and that the perception of our program was that we were here to help lift up asset-based, community-driven work. And we can't really create equity if we don't have buy-in and value in the work that we're doing. Does the effort worsen or ignore existing disparities? And then based on all of that, what revisions do you need to effort under the discussion, right? So I added a couple of other questions. One, who holds the power? As you're moving through this impact analysis and whether or not you're advancing health equity, whether or not you're being successful and considering oral health equity, are you also considering who holds the power? That could be related to funding, it could be related to access, it could be related to resources. So are you holding the power? Are you being equitable in sharing the power? And lastly, I really think it's important to consider whether or not we're inspiring hope. Are we inspiring creativity? Are we inspiring quality and value? And all of those really abstract things that are actually really critically important to achieving health equity that are often underlooked or perhaps even undervalued. And then I want to point out, because Kathy mentioned in the chat, what communities should we be including? And she actually brought up that there are severe inequities among disabled populations. And I think this is critically important for us to consider what communities are being included in the process. If we are not intersectional and inclusive, we are not going to be successful in advancing oral health equity. So some examples could be, rural communities, those who are historically excluded, those who have chronic disease and disability, all of those social inequities that we know come from being historically excluded. And I really liked this piece from the American Journal of Medical Care. I pulled it out because it felt like a lot of disadvantaged populations were listed here. And I also think it's really critically important when we're talking about vulnerable communities or vulnerable populations. The language that we use is critically important. I have shifted away from using racial minorities and instead talking about minoritized populations, because it puts the onus back on people who have privilege. So, people who have racial privilege, people who have power privileges, that we have been the gatekeepers for far too long with all of these communities, that we have historically excluded them. It's not that they are vulnerable because they've chosen to be that way. We have put them in those positions. We have created systems intentionally that breed these disparate outcomes. And so we really need to understand and shift the language that creates an equitable understanding of how we got here too. I've used this a few different times, and I think it's actually a really nice visualization to talk about all of those different types of identities that can facilitate or create a barrier when it comes to health equity. When we're talking about intersectional work, we have to really consider all of these different intersections. That can be personal. It can be, how I identify, my age, my physical ability, all the way up to all of these cultural implications. And there is an intersectional lens that we have to approach for oral health equity. And if you'll bear with me a moment, I really like this quote. So I know everybody here can read it for themselves, but I would love to just share it aloud with you. That when developing or applying an intersectional health equity lens, we have to engage in deep self-reflection that contextualizes and recognizes the ways in which race, gender, class, sexual orientation, disability, and other axes of inequality can constitute those intersecting systems of oppression. These systems produce very different lived experiences for entire categories of people who are embedded within complex webs at different levels. And critical self-reflection, which is what a lot of what we're doing here today, critical self-reflection allows researchers and practitioners to continually and closely examine their own race, gender, class, sexual orientation, disability, language, citizenship, social position, and our own relationships to those systems of inequality. So, lastly, and I think I'm going to leave about 10 minutes for Q&A or just chat and discussion, and I would love to invite anybody else who's a panelist to jump in here and discuss with me. Conclusions and recommendations. So thinking about all that we've sort of considered today in terms of health equity, where we are, where we need to go, where are our gaps, where are our opportunities. Here are some recommendations that I think, here are some arguments that I can make for where we really need to go. And number one is that I think we need to define, and then as a result of a definition, actually measure how we are advancing oral health equity. I think as a researcher and a biostatistician myself, and as somebody who's still deeply involved in research and evaluation, I really struggle with not having a standardized definition and a standardized way of understanding how we're practicing oral health equity. We can't advance something that we don't know how to even measure it, what it looks like on an individual level, what it looks like on an organizational level, on a structural level. And oral health equity, many times, which we see in the healthcare system broadly, oral health is folded into broadly health. And sometimes we're excluded completely. So I think there's a real case to be made here that we really need to define and measure oral health equity. And we need to adopt a real intersectional approach to oral health equity. And that's been reflected here in the comments that all of you have made. And it seems to me that this is really tracking that there are so many differing opportunities here based on, again, all of those historically excluded communities, whether or not you have access to oral health care, that it can depend on whether or not you're in a rural community. There are so many different ways that we can consider intersectional approaches to oral health equity. And the argument can definitely be made that many of you are already practicing this. But how can we do this better? How can we amplify each other? And how can we collaborate in this work? And then lastly, we really have to dedicate focus to anti-racism, and specifically in oral health. There just simply isn't enough research and there isn't enough information for us to dedicate a true oral health anti-racism praxis for practitioners, for researchers, for nonprofit leaders, for community members. You know, racial equity is something that we cannot advance health equity without advancing racial equity. And there just isn't enough information and enough dedicated focus on what anti-racism actually looks like in oral health. So there's a great opportunity for us to really work together and figure out what that looks like. So then, again, if we can define it and measure it, then we can advance it. So that leaves 10 minutes for Q&A. And I just want to say thank you so much for allowing me to talk to all of you here today and present some of my thoughts here with AIDPH and how we can be more unified in approaching oral health equity. So with that, I'm going to stop sharing my screen. And I would love for you to either chat in any questions or you can also put them in the Q&A box. And if not, then I am also free to yield the floor to Stacy and Christy. Oh, okay. Just a comment about local access in West Feliciana Parish. I am not in the best position to answer that or comment on it because that sounds like a very local Louisiana comment, but thank you for amplifying that. I'm sure that there's opportunity to discuss that throughout the conference, or if anybody else would like to tackle that. Okay. So hearing none, I'm not seeing any more questions or any more comments. And so I'm happy to close my presentation and yield the floor. Thank you again for having me, and I look forward to sharing the day with all of you.